Hi everyone, my name is Odalis and I'll be presenting for my group, which is Group G. And the overview is that what I'll be talking about is the nationwide nursing and primary care physician shortages and how the U.S. is facing broad shortages, which threatens the access, quality, and sustainability of healthcare delivery. So on this slide, uh, we're looking at the crisis at a glance. The America is facing critical shortages of both nurses and primary care physicians. There's expected to be up to 86,000 physicians short by 2036 and up to 78,610 nurses short by 2030. These shortages aren't just future predictions, they're being felt now. These shortages burden existing clinicians and limit patient access. Now, why is a shortage growing? Well, first we have an aging workforce where outpacing many clinicians are now reaching the age of retirement. And there's a true bottleneck where there is faculty, clinical sites, and GMP slots. A lack of training spots impacts the replacement for those nearing retirement. For example, COVID-19 left many nurses and physicians burned out post-pandemic, which many decided to leave the profession. There's also uneven geographic distribution, which with this maldistribution affects the rural and urban underserved areas. The financial and policy barriers, which is the funding and compensation structure, influence provider placement, and in the end, there's just no single cause to such a complex issue. Now, looking more into the training capacity limits, nursing facility shortages are a major bottleneck. For every faculty vacancy, many student applicants are denied. The education pipeline as nursing programs turn away qualified applicants due to limited spots available. Faculty shortage placements. There's also federal caps that restrict new physicians. These federal caps are tied to long-standing caps on Medicare-funded residency slots. Now, looking into the counter argument, the shortage of nurses and PCPs, which is primary care physicians, some experts may argue that the issue is not some national shortage, but instead a maldistribution of providers. To expand on that point, training programs, as said by experts, are producing enough nurses and PCPs, but they're not being distributed where needed. On one hand, we have urban areas that have high provider nurse density, and then we have rural underserved areas that lack providers and nurses. Policy changes should focus on incentives and placements, not just increasing workforce. Incentives can help with being able to distribute more nurses and physicians to the more rural, underserved areas, allowing for better patient access to healthcare services. Impacts on patients and providers. The consequences of nursing and PCP shortage and maldistribution is longer wait times that in return reduce primary care access. The shortage also increases the volume of patients per provider that increases the amount of nurses and physicians experiencing burnout. The population at the end impacted the most from this domino effect is rural and low income communities. So, who's working to fix the problem? Well, we have a couple organizations that all play a different role, but the coordination among these groups is essential for lasting solutions. We have the HRSA, which I'll focus on more on the next slide, that provides funding and identifies shortage areas. And it does this through training grants, loan repayment, and nurse corporations. The AAMC drives physician workforce policy and data. The AACN focuses on nursing education capacity as well as faculty incentives. State health agencies influence loan repayment and incentive programs for underserved areas. And lastly, we have the health systems and foundation, which they help build pipeline and faculty funding. On this side is our key organization and key leader, which is their key leader's profile to a solution to the shortage of nationwide nurses and PCPs. The organization chosen, which is on my right, to solve the nurse and PCP shortage is the HRSA, which is short for Health Resources and Service Administration. They are the primary agency within the U.S. Department of Health and Human Services. Their mission, as stated on their website, is to improve health outcomes through access to quality services, a skilled health workforce, and innovative high value programs. The HRC's vision is healthy communities and people. To put their mission to action, they provide healthcare to those geographically isolated and economically and mentally vulnerable. They also support health infrastructure by training of healthcare professionals and the distribution of the healthcare workers in communities that are in need. The HRSA also provides programs that provide discounts on prescription drugs that in return facilitate organ, bone marrow, and cord blood transplantation. They address the most pressing concerns, which are the chronic disease epidemic, mental health crisis, obesity, nutritional deficiencies, and exposure to chemical and environmental toxins. Now, looking at the left side, we have the chosen key leader, which is Thomas J. Ingalls, who is the Administrator of Health Resources and Services Administration of U.S. Department of Health and Human Services. His job is to oversee HRSA's efforts to expand access to quality healthcare. Some other important things to add to that profile about this key leader is that he has directed the management of the 175 billion COVID-19 provider relief fund, which provided relief and assistance to hospital and other healthcare providers at the front lines of the COVID-19 pandemic. He has also completed the most significant reorganization of the agency in a 40-year history. He also served in the White House Coronavirus Task Force. After looking closely at some of the key leaders profile aspects, we also want to take a look at some of the skills that I feel from the modules that apply to Thomas J. Ingalls. And first, we have the three A's of value-based leadership, which are the ability, action, and achievement as a leader. So for that one, Thomas J. Ingalls, as stated before, he was able to reorganize the agency in 40-year history, also managing an agency through change during such a time, especially during COVID-19. It takes a lot for a leader to be able to take control during a time where there's a lot of chaos and a lot of questions. I feel like that's a skill that's very important to have as a leader. Also, using the same example of him reorganizing an agency and managing it through such a difficult time as COVID-19 pandemic was leading an organization through change, which is described as one of the most difficult yet essential skills for a leader. And lastly, his conflict styles, as described by Thomas Kilman, conflict mode instruments. I feel like his conflict style, which looking at the examples of him and his profile and his job, which is to stay within funds for training programs, He uses more of a compromising style of conflict because he does have to be able to stay within budget because he has to manage and know where to place certain fundings to certain places. And he has to compromise where to put it or where it may be needed first. I feel like that style could help him, but he could also have more of an accommodating style, which looking now that we see that there's limited training spots, he could put more money into his training facilities to have more training sites and spots for those trying to come in and um, become nurses or physicians or nurse assistants or even CNAs, which in return increases the volume of providers, increasing the patient access which allows access to the healthcare, which then reduces less volume of patients for each nurse, less burnout, and it improves the quality care. The efforts to expand access to quality healthcare through grants awarded to state and local government, which is what he manages, of providers of healthcare professions training programs. This is key because with the more grants, as mentioned before, and providers for training, it allows for more access for those interested in the field. And that is the main solution, as there will also be lead to better distribution of nurses and PCPs, especially to those low income areas that are in more need of access to healthcare. Now, solutions that work. We have expanding nursing facility, clinical sites, and GME slots, increased loan repayment and rural services incentives. We also have to improve retention for mental health support, safer staffing, and career pathways, broaden team based care, and build community pipelines from K to 12 careers. I also want to stress that solutions must operate on multiple levels of training, practice environment, policy, and community. Increasing retention is just as important as recruiting new clinicians. So, being able to keep these physicians and nurses, which means being able to have enough of them to not cause burnout and have them want to leave the profession is important. I also want to highlight that team-based care can extend capacity without replacing any single profession. Now, the shortage is real, growing, and it's solvable. Workforce size and distribution both matter. There's multi-level strategies are essential, and long-term investment will improve patient access and clinician well-being. This is a national challenge, but not an unsolvable one. I encourage everyone to consider the importance of policy change, funding, educational workforce development as well. And that is all for this slide. Thank you everyone for listening. Bye.